Black Edition Season 5. Yeah, so we have today, again, Dr. Ma, our presenter for this Season 5. The topic today is cardiac neurosis, anxiety, and the irony. Dr. Ma is no stranger to everyone. Yeah, he's going to lead us to these two very interesting cases. And also, Dr. Kok Wei will be joining us also as a chairperson. And also together we'll lead you through the cases and we'll have a great discussion about this topic. Yeah. So, Dr. Ma, do you want to start with the case first?
Sure. All right. Follow, make me the presenter, please.
Ball on you, Dr. Ma.
Okay. Great. Can you see the screen? Yeah.
Yep.
Right. Thank you so much, ladies and gentlemen, for joining us for the 5th season of EP in Everyday Practice. Now, this season is a bit different. There's a bracket there, as you can see, Black Edition. Title is Cardiac Neurosis, Anxiety, and the Irony. And this season is special because it's a commemorative season, meaning that is a kind of a mini celebration of over the 5 times that we have done this. And we owe the success of this season very much to you all, because you all have shown much love and also support this series. So please continue to tune in to our series. We have much more to come. I've nothing to disclose. The preamble this time is a bit different. I'm going to ask my audience back a question. Have you all ever heard of the diagnosis of cardiac neurosis? Now, I'm not going to call you all for this question, but I'm sure the answer is pretty much yes. You have come across at least, albeit you may not have made one yourself. Now, what is the definition of cardiac neurosis according to ICD-10, International Classification of Disease? This is not the ICD that we used to talk about. Cardiac neurosis is defined as heart complaints for which no the ICD explanation also is mentioned there. Other common terms used to describe this condition are like cardiac anxiety neurosis, cardiac anxiety disorder, cardiac phobia, functional heart complaints, or this long winding diagnosis called somatoform autonomous functional disorders, which is a mouthful. Now, I dig a bit deeper into ICD-10, and this is ICD-10 version 2020. And you can see that if you want to diagnose a neurotic disorder in a patient, you need to go under the subsets of F48.9. And under this 48.9, if you want to diagnose cardiac neurosis, it falls under the category of F45.8. Now, let's go into F45.8 and look at it. Now, one glance, you already get very surprised because majority of accompanying condition under this category, they are all psychiatric disorder. For example, psychogenic dysmenorrhea, psychogenic pruritus, teeth grinding, all this should be under psychiatry. So what's going on when we diagnose a patient with cardiac neurosis? My take is, if we call this patient having a diagnosis of cardiac neurosis, we should be better sending the patient to a psychiatrist colleague because they are the expert in this, according to ICD-10, the latest edition. But I like to say this. This is the definition put out by ICD-10. But in practice, in all honesty, when we diagnose a condition, cardiac neurosis, we are saying this. We diagnose cardiac neurosis when a patient complains of certain cardiac symptoms, but all cardiac investigations are normal. This is what I call in-practice definition, or the honest definition. Right or not? Look at this. When a patient has palpitation, you run all these arsenal of tests, ECG, stress test, echo, chest X-ray, Holter. Some of them even be subjected to invasive coronary angiogram. If all this arsenal of investigation turn out to be normal, then you move on to call this cardiac neurosis or anxiety disorder. True or not? Just ask yourself this question. Now, first case, I call this everything but the heart. It's a Madam S, 51-year-old housewife. She has got hypertension and on treatment, amlodipine 5 milligrams. She's been having palpitations since the year 2013. Every time it happens, she would feel very anxious. She has been a type A personality for a long time. She presented to A&E several times. ECG had always been reported normal. Over the years, saw several cardiologist colleagues and extensively investigated. Now, these are the tests that she has been done. All blood tests normal, 2 times stress test normal, 2 times echo normal, 1 time CT angio, and 1 time invasive coronary angiogram. And she has a whooping amount of 5 times a Holter, all reported to be normal. She's been tried on beta blocker, calcium channel blocker, and momentarily on ivermectin to no avail. The last attending colleague actually put forward this diagnosis, say that you have been extensively investigated, nothing wrong with you. Your diagnosis is cardiac neurosis. Just take a good rest and relax. The thing is, now she's presented again to you. Now, she's complaining of palpitation at that very moment. And you did an ECG, of course. Now, she's having palpitation during the time the ECG was done. Now, look at this ECG for 5 seconds or to 10 seconds, and we go to the next poll. Very easy. Just tell me if this is a sinus rhythm or not. Are the polls coming in? This is the easiest poll of all because there are only 2 choices.
Now, maybe you can go back to the ECG so
Sure.
that people can have a look at the ECG.
Okay, no problem. This is the ECG.
Right. So is this sinus rhythm or not sinus rhythm? I think a lot of people will be thinking whether this is a trick question or not.
But let me put it to you that no trick here. At least not a trick that I intend to. If you feel so. That even gives a bit more layers of suspense there. I don't see the polls are coming in. Oh my goodness. My audience are thinking very hard. Okay, that's a good sign. That's a good sign. Over the years, I keep on telling my EP buddies, it's getting harder and harder to impress our intelligent audience on arrhythmia diagnosis. So because they are so good already in their knowledge and assessment, it's difficult to impress them, actually, which is a good sign. Polls coming in, Corey?
Hello, the time limit is 2 minutes. I think 2 minutes is a bit too long.
Okay, I'll change it to 1.
1
Sure.
minute will be probably more than enough.
Yeah.
Everyone have voted?
Let's see. Okay.
Okay, Carlo, let's show the poll. All right, so actually quite a lot of people have already voted. 64% think that it is a sinus rhythm.
Yeah.
4% think that it's not a sinus rhythm, and 32% think that you are putting a trick on them. No answer.
Okay, good. Let's move on. Now, before I review the answer, I really need to say this and allow me to walk my audience through this very important key point here. When a patient presents to you with the symptoms of palpitation, your most powerful arsenal, the weapon that you have with you, is history taking. You must spend at least 20 minutes taking history. Just joking, but the fact is, the idea is you need to spend time with the patient. Now, I call this the mantra I take. These are the mnemonics. STOP. S stands for symptom complex. Let me tell you what do I mean by that. I will ask the patient, what do you mean by saying palpitation? I give patient 3 choices. I will tap on the table, but you won't be able to see me. I will clap my hand like this. When you say you have palpitation, do you feel your heart beating like this? Which is obviously slow. Or second choice, a bit faster, but not very fast. Or third choice, very fast. So it gives you an idea where you start, because if the patient tells you that I have palpitation, but it chose number 1, it may not be really a fast heart rate palpitation. If it chose number 2 or number 3, then you need to delve deeper into it. Now, this is symptom. And the patient say, I chose number 2. In the middle. Not very fast and not slow, but in the middle. Now, what is time? Time is what usually the time they experience palpitation. It gives you a clue. For example, the patient say that I have palpitation whenever I about to go to work. You know, it may mean that they are really anxious when they are preparing their day for the work. But if let's say the patient gives you this answer, it happens all the time. There's no time preference. Morning, night, noon, it will happen, it just happened. It is something there if patient tells you so. Third is onset or offset, means that how did it start? How does it start? Did it start slowly over a couple of minutes, or you start suddenly? What's the offset? If it stops suddenly or it stops slowly. This patient said it came suddenly for a few seconds, just gone. Fourth is provoke. Now, this is by far the most important question you ask a patient. I often write in my notes, this palpitation provoked or not provoked. Provoke means, were you doing something at that time? Were you doing exercise, or you're anxious? You're cooking, but then you feel like you are rushing for the meal already because you are short of time. If the answer is provoked, okay, it may not be pathological, but it's unprovoked, it means something. Again, this patient told me that, no, I was watching TV, all of a sudden it just came. And it went off just by a couple of seconds or minutes, it went off. And further history also, she told me that now she's having daily symptoms. Before there was less frequent, once every week or so. Now, there's a point of consideration for the diagnosis of cardiac neurosis, so because she stressed to me, hey, doctor, every time it comes, I'm worried I have a heart attack. Appearance, very anxious. Almost like luring you to make the diagnosis of cardiac neurosis. Now, choose with you, with that ECG, which you have voted the answer. What would you do next? The question is, how would you proceed to manage this patient? I start from number 5. Number 5 is, now the above, I don't want to do anything else. Confirm cardiac neurosis with that ECG. Next case, don't waste my time. Or you want to repeat an ECG, repeat a stress test, repeat a Holter, or repeat a echo. Please vote.
Okay, the poll is open now. So, Mark and Kinta, I can see that there is questions coming in. There's one question coming in. Are we going to address the question first or later?
Maybe you finish the case first, the first case, and then move to the second case. We answer all the questions there. The answer may be at the, in the middle or the end of the case.
Yep, correct. All right, the poll has ended. Let's see the result. Okay.
All right, good.
Okay, let me see. Wait, the A. Okay, most of our colleague here answered D, donkey. Repeat Holter.
Repeat Holter. Yeah.
Right? Repeat Holter. I agree because I did that. In fact, the patient presented to me. That's why I know. So I did that because I asked the patient history. So now you're happening every day. Eh? Sure. Yes, every day, doctor. It comes few seconds to a minute and this went off. Okay, we repeat a Holter then. Now this is a Holter. This was a Holter result. Holter QRS complex, over 100,000 QRS complexes, which are within the normal range. You guys know that if your total QRS complexes below 80,000, it's not a valid study. You all know that, right? Because it means that the lead is falling all over the place already. Too few QRS complexes. Normal here, max heart rate 138, mean heart rate 44, supraventricular beats less than 1%, no VT, no AF, PVC less than 1%. Now this is probably, I can frame it like the answer, because she pressed the event diary for 17 times throughout the 24 hours duration. Now this is one of them, and pretty much all other 16 look pretty much the same. She's having palpitation at time. Look at this event strip for 10 seconds and tell me what you think. It happens at 4:23 p.m. in the afternoon. She's having palpitation at the time. Exactly the same palpitation when she presented to A&E. What would be your assessment, means your impression or diagnosis now? For those of you voted for sinus rhythm, would you stay the same? Of course, this is sinus rhythm because when she's having palpitation, she pressed the button. This is sinus rhythm. So cardiac neurosis confirmed already. Or you want to choose, just on the safe side, repeat another Holter. Or 3, something else. Please vote. The majority say that it's a done deal. Case closed. Nail in the coffin. This is cardiac neurosis because when you have palpitation at time, your diary event recorded sinus rhythm. And 30% of them say something else. Now for the 30%, I will congratulate them because you need to do something else before you commit to the diagnosis. Because you need to take a step back and look at the big picture. Now, big picture is called the full disclosure, which I have actually talked about in season 2. You can go and check back my season 2 video. Full disclosure is extremely important because full disclosure allows you to see how does that fast heart rate tachycardia or slow heart rate starts and where is the zone of transition. Now, if you look at here, it's labeled as N. N means normal. Normal, this is the spot where she complained of palpitation. If you scroll back to see how did it start, then you realize that something is wrong here. Let me pull out my pointer here and show you. Look at here. This is normal sinus rhythm. Normal, 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 maybe normal, maybe not. But this one definitely is a supraventricular beat. And it started it off from a slow heart rate, jump, doubling it, tripling it. How can this be sinus rhythm or sinus tachycardia? And the patient complained of symptoms at the time. And in just to echo what Dr. Paul said, the annotation is wrong here. Look at this, N already. After some time, the computer give up. How come? I thought it's S, supraventricular beats, but then it's kept the same. So I also think it's normal. Normal. These are all supraventricular beats until the end. So taking a step back is crucially important, ladies and gentlemen. Now, how did it get initiated? Zone of transition here. Again, normal beats, normal beats, normal, normal, normal. If you calculate the number of big boxes, in between Chiari's complexes, there are 6. 1, 2, 3, 4, 5, 6. Look at this beat. This beat came a tad earlier. So this is already a supraventricular beat. And this came a tad earlier, and then initiated the tachycardia here. And by taking a step even further back, I call this going in a dark room, like developing the old style photography here. Go inside and appreciate the details, appreciate the big picture here. If you look here, blue box represent slow heart rate, normal heart rate. The red box represents fast heart rate, tachycardia. Look at it. It's all over the place. How can a patient have sinus tachycardia interspersed with normal heart rate? It doesn't behave this way because sinus tachycardia should have a warming up slowly and cooling down slowly phenomenon. That's physiologic. And if you take one straight out and look at it, this one cannot be sinus tachycardia. Rapid heart rate just stopped all of a sudden and got reinitiated back with a PAC. And the cycle continues for over 50 times in that short period of time. It contradicts the physiologic pattern of gradual warming up and gradual slowing down of sinus node. This is not sinus node origin rhythm. So it's not sinus rhythm. The answer is ectopic atrial tachycardia, or you simply can call it atrial tachycardia. And one thing funny is, at some time, and in fact most of the time, the tachycardia rate was at 70 to 80 beats per minute. And look at here, I use a computer caliper, it cannot be wrong, 72 beats per minute. And if you glance back, her initial presenting ECG where she was already complaining of palpitation, the rate was at 76 beats per minute. In fact, she was already in atrial tachycardia at that time. But you look at it, how can it be? The heart rate is way below 100. And the TB morphology also look very much like sinus rhythm. I agree with you. Before reviewing the final layer of the answer, let's call on how to manage this patient. Now that we know that she has ectopic atrial tachycardia, would you still want to try her on antiarrhythmic drugs? Maybe it work this time? Or you call in the finite? Please poll. I hope I get like 90% at least.
So this patient was already on beta blocker, is it?
She tried momentarily, but she stopped. It didn't work, and she tried for like a couple of months. In different intervals, couple of months, couple of weeks, and stop. Never worked for her.
Yep.
That's why I question: you want to try again or not? If you vote to try again, then you are against the guidelines, in a way, because when you fail one antiarrhythmic drugs, you need to offer the patient, at least offer. I'm not saying that the patient should go to, at least offer the patient ablative therapy. If the patient say no, that's okay. But if you follow guidelines, you should offer. Oh, poll has ended.
Okay, the poll has ended. So I think the trick question is B, you're asking about the definitive management. And I guess most of our audience will probably agree with you that she needs ablation.
Yeah. But it's not 90%, it's 50%. Okay, I'm happy. Don't worry. Let's move on.
I think the 40% is in doubt, whether maybe they doubt that the ablation probably carries some risk. I think most of the physicians will probably have that kind of mentality. Yep.
Sure. Understand. ECG post RFA essentially almost the same. The rate is almost the same, but there's something here I want to show you. Let's talk about normal conduction system. Now, I've already showcased this in several conferences. I used to say that if you want to know whether the patient has sinus rhythm or not, look nowhere else other than lead AVR and lead 2. Because lead AVR is the lead that points towards the right shoulder, the SA node is high up in the right atrium. When it fires, it captures the atrial tissue from top to bottom, cranial to caudal fashion. So your P wave in lead AVR should be negative. And your P wave in lead 2, which is exactly the lead, look exactly opposite towards your lead AVR, will record a positive P wave. Make sense? Yes, it's very easy to understand this. Now, what if I tell you there is an ectopic pacemaker, ectopic focus, which is running slightly faster than a sinus rate? It overrides the sinus node all the time, but it's slightly lower than the sinus node. It fires and it captures the atrial tissue in almost a similar fashion from top to down because it's just below the sinus node. So you still record lead AVR P wave being negative and lead 2 P wave being positive. Now, at this juncture, you may wonder, the same, what are you trying to tell us? Look and behold the subtle difference here, before and after. Because before that, the atrium has been commanded by an ectopic foci lower than the sinus node. So when you capture the atrial tissue from top to bottom, because it's lower, so it captures less tissue from top to bottom. There's some tissue captured from bottom to top. So you cancel off the P wave amplitude in a way that it causes the P wave still positive, but less amplitude. The height shorter. Now, if I cannot convince you by lead 2, look at lead AVR, before and after. Now, the point of depolarization is really higher up already because you have a deeper amplitude taller, deeper inverted P wave in lead AVR. And that is the thing that you really need to look when you assess patient with palpitation when you do ECG. Question to me, myself, I'm sure some of you will ask me, look, I understand that the focus is very close to the SA node. That's why I didn't choose ablation because it's very dangerous. When you ablate, you may injure the SA node because it's very close by. You just showing us that. How can you be so sure not to injure the SA node? Because if you injure the SA node, then the patient needs to be put on a pacemaker. The help of three-dimensional mapping system. Now you look at here, as Dr. Kaur has already alluded to you earlier, this is the SVC and the IVC here. The sinus node has been mapped, tagged with different color, blue color in this case. You can choose different color. You can choose gold color or pink color if you like pink. The color doesn't matter, you choose. But the focus of abnormal rhythm, atrial tachycardia, been tagged as red color here. As you can see from the map here, when we put the ablation catheter, which you cannot see clearly, it's been ghosted, like hiding behind, but you can see something behind here. We put the ablation catheter right onto the focus of abnormal discharge, the foci of ectopic atrial tachycardia. When you ablate here, within 20 seconds, we're able to cure the patient from atrial tachycardia. And you can see here, follow up to 2 years now, the patient has been maintained in sinus rhythm with no evidence of recurrence. I only did 3 times Holter on her, but every time I see her, she said, okay, so I did not pursue Holter at 1 year. You all can do Holter every month for a patient, but this patient is doing fine. She's been asymptomatic ever since then. Strange that we can cure cardiac neurosis using ablative therapy. Now, application in everyday practice, jokes aside, my dear colleagues here, remember, cardiac neurosis is a diagnosis by exclusion, meaning to say that you need to exclude, rule out any plausible organic causes before you subject this diagnosis to that patient. And that is very important. And that includes excluding all cardiac arrhythmias. I know there are a lot of cardiac arrhythmias that are difficult to be diagnosed, but if I may say so, before labeling the patient cardiac neurosis, maybe, just maybe, calling in the help of a cardiac electrophysiologist is one of the many options. Second point is, we need to be cognizant and realize that the so-called normal heart rates between 60 to 100 beats per minute, they are not descended from Bible or descended by God. It's not cast on stone. Who said the heart rate of 76 beats per minute cannot be ectopic rhythm? Who said the heart rate of 120 beats per minute must be pathological? The patient will be exercising. And who said, by the way, this is my season 2 reminiscence. Who said the heart rate of 36 beats per minute need a pacemaker? Absolutely. So 60 to 100, we call it normal, but it's not an absolute term. And always, always, always ask for full disclosure in any Holter tracings. You will thank yourself for doing so. Trust me. And last but not least, what is the key in arriving to diagnosis in this case? Is that deciphering the height of the P wave? Is that deciphering Holter? Yes, but not even near. Is the patient's own word, is a history. Patient history is the king in arriving the correct diagnosis in atrial tachycardia or any arrhythmia diagnosis. All right, with that, let's move. Listen to patient. All right. All right, are we time to move on to the next case?
Yep, go on, Mark.
Okay,
Right.
Next case is hot from oven. Only about a couple of weeks earlier, I've met with this patient. I call it wee hours SOS. 38-year-old man, pre-morbidly very fit man. Actually, he does a gym session very often prior to MCO. He came to the A&E at 11 p.m. at night, complaining of episode of palpitation throughout the same day. The physician on call, my buddy, physician on call, saw him and determined that everything looks normal. He checked his blood pressure, heart rate, O2 set, blood tests. He did ECG, chest X-ray, all normal. But because I'm EP on call, 365 days now in my hospital. So he called me, the EP on call, and said that, hey, Ma, we want to come and see, but 11 o'clock at night, not sure where to come. Of course I came. I drove my ride to see him at 11:30 at night because I felt something amiss. Now, these are his exact own words. Doctor, in fact, I must let you know that I have anxiety problem past 2 years. My doctor told me. I have this on and off one, fast heartbeat. Caught me off guard. Came unexpectedly, but very frustrating. Every time I go to the hospital, sure stop one. ECG always normal. I guess this time also normal, right? He asked me. I said, yes, normal. Now, this ECG, I urge my audience not to belabor too much on the height or the depth of the P wave they lead to an AVR simply because listen to the patient. The patient said, stop already. So just move on. This is sinus related, okay? But the question is, what would you do next? The patient has got symptom. We talk about the mantra just now, STOP, is unprovoked. He was not doing anything at the time. He just came the palpitation. Ring a bell already. Would you allow the patient home? TCA 1 week and in my clinic. Just look, see, okay? Or you allow home, anxiety, go to see a psychiatrist. Or allow home, outpatient Holter, just okay now, blood pressure, everything okay. Or admit for telemetry. Or prescribe Xanax, anxiolytics. Please vote. Two weeks ago, I saw this patient. Very interesting. Yeah. Polls are coming in. Yep.
Oh, sorry, Ma. Just now I was actually talking, but then I noticed that I was muted.
You who muted you? Who dares to mute my Dr. Call?
I muted myself.
Okay.
Never mind.
Can get no problem. Would you want to repeat the things you said just now?
Never mind. We will see the poll first. Oh, okay. While waiting for the poll, no, I was talking about nowadays we use a lot of this smartphone based kind of rhythm monitoring. So how often your Ma, you use this kind of monitoring device?
I use quite often, but only for those patients with very intermittent symptoms. If they say the symptoms is frequent enough, I either give them a Holter monitor, event recorder, or I admit them for telemetry.
My
Okay.
side I use quite often also, mainly, and now because actually now patients sometimes they spontaneous offer that they have this smartwatch, the latest one, the Apple 4, and they can Apple 4, Apple 5, I think can record their ECG themselves, or they buy the cardiac the mobile smartphone ECG monitoring. So we use it like a rhythm card. We give it to the patient and then they record. We are able to access it from the web, and then anything that they have abnormal ECG, then they can alert us, then we can have a look of it. But I would say that the quality of the ECG recording depends on the patients. Some patients, a lot of artifacts from the ECG, so a bit hard to interpret. But some of them, they get a very good ECG, then it's quite okay. But from the usage pattern, after a while of 1 or 2 weeks, some of them actually they stop using it already.
Yep.
This is why I have.
So I think the CCAP setting and the private setting is a bit different. Private setting, I think the smartphone base is probably cheaper for intermittent symptoms. If you repeat like 10 times Holter, it's going to cost the patient bomb on it in private.
Yeah, absolutely. So for intermittent symptoms, I usually, I sometimes don't even see them back. I just offer them this on-demand ECG like a cardiac. So I say after you buy this, I give you my email address. So if you have palpitation, record it, PDF the whole rhythm strip, and then send it to me. If I think it's abnormal, I'll call you in again. Yeah.
Right.
All right.
Okay, back to the poll.
The poll shows
yep.
majority, I think, say telemetry, for the call.
Yeah, correct.
Yeah, all right, let's move on. This was his telemetry at 4 a.m. in the morning. Sinus bradycardia, normal guys, don't get surprised. But what happened before that is the one that clinched the diagnosis. Look at here. Now, it happened many, many times, throughout night, 20 over times, and in daytime also, correlating with symptoms is burst of fast heart rhythm interspersed with slow heart rhythm, normal heart rhythm. So with this, it's almost the same as the first case. This cannot be physiologic, warming up and cooling down, because it's just too sudden. And that time patient is having symptoms. What would you do next? Oh, still try some Xanax, okay, no harm. Try a beta blocker, try calcium channel blocker, whack with the strongest antiarrhythmic drugs known to humankind. Done. Or call in the finite, please vote.
I think in this era, probably you miss out another agent called ivabradine.
Okay, Ken, no problem. No problem. You can vote that, categorize that under beta blocker.
No answer.
No answer, yeah.
Okay.
No answer. Then it should be the highest no. No need to make it happy, because it's not my intention to actually tell you what to do. Later I explain that in a moment, yeah. So let's see the poll first. See how it goes. Remember, this patient was not tried on any antiarrhythmic yet. So
all right, probably let's look at the poll.
Okay. So
Call in
43% say call in the finite. And by the way, finite means the electrophysiologists who can do ablation. Me, Dr. Kaw, Kok Wei, and Dr. Kaw Ting Tat. Yeah. Now, what's the correct answer? All potentially correct answer, except anxiolytic maybe. The patient hasn't been tried on antiarrhythmic drugs. So you follow guidelines, you can still try. No harm. With the exception of amiodarone, it's too big a gun. I would discourage it very much. Discourage. Don't use amiodarone. Beta blocker, CCB, okay, you can try. And calling finite, of course, is going to be one of the right answer. And similar to the previous case, we map out the sinus node first using 3D mapping. You can see here the sinus node activation here is called a propagation map here. This is the SVC and down here is the IVC. And you see here, this is the origin of a sinus node. Pretty much the same as what Dr. Kaur has explained to you. Depolarize the atrium from this spot. This spot is the earliest one. The following slide, I need to tell you, alert, black edition alert. One slide contains some gross picture, which may upset you. Let's go it. Okay, when we ablate, and you can see this ghosted form of ablation catheter at the mid Crista terminalis here. When we ablated here, we accelerated the heart rate to a clinical tachycardia, and upon ablation for 20 seconds, it breaks, terminated into sinus rhythm. So you can see how beautiful it is. With 3D mapping and radiofrequency ablation, we are able to cure this patient from the struggle of a long time arrhythmia that has been haunting. 1 month follow-up only, because with very fresh case, entirely asymptomatic now, no more palpitations. He's able to go back to his gym now. No thanks to MC Ho, he missed quite a lot of sessions. So pending Holter in 1 month. I'll tell you all what happened to the Holter in 1 month. But basically, I call him just now, in fact, before the webinar. I call him in the office. I call him, how are you? She said, perfectly fine. No more palpitation. Now, recalling these two cases, my audience will ask me, both also had their AT foci mapped to this structure called Crista terminalis. What is this Crista terminalis? Or Crista terminalis is in Latin, so basically in English term, it means terminal crest. What is this? A bit of relevant cardiac anatomy here. You can see that this is a SVC, this is an IVC. The SVC and IVC, they are both being connected by a fibrous band that run across longitudinally in the right atrium. And this fibrous crest is called Crista terminalis. This is a sinus node which is situated high up at the roof of a RA. And the Crista terminalis is a long structure. And the superior part of a Crista terminalis is very close by to the SA node. And mid part and the inferior part. For the second case, the focus is being located and localized to the mid part of the Crista terminalis. Now, why Crista terminalis is so important in electrophysiology? Because of this. We call it the ring of fire. This Crista terminalis has been the hot spot to harbor abnormal foci of atrial tachycardia. Very, very high. Across different series, some as high as 50%, but some up to 40%. This is one of the hottest spots in the whole atrium. Combine both right atrium and left atrium. Fine. This is one of the hottest. It's still the same old saying, listen to patient symptoms. If the patient say, out of nowhere, I've had this palpitation, I was not doing anything, albeit it's very short lasting, when the patient has symptoms, listen to the patient. At the bare minimum, listen and investigate the patient. Give the patient a chance. And if you listen to the patient, you arrive to the correct diagnosis. Upon proper treatment, you spare the patient's long quest for a cure. And this patient is not very long, but the first patient was longer. You can recall in my season 3 is even longer. That patient spent about 8 years looking for a cure. And at the same time, you spare yourself of this unnecessary, what I call is quasi-psychiatric diagnosis. It's like half-hearted. You don't want to send to your psychiatrist colleague, but you call it, I think it's nothing. I think it's not cardiac. It's some, cardiac neurosis, psychiatric, quasi-psychiatric. Try to reframe yourself by doing this until you make sure that this is not a cardiac arrhythmia. And one of the many ways to achieve that is to enlist the help of an electrophysiologist. In summary, one image, who knows what's this? BLM. This has taken the world by like hot fire. BLM, Black Lives Matter. Now, I'm not going to talk about Black Lives Matter because I'm not qualified to talk about Black Lives Matter because I'm not a social scientist and I'm not a political scientist. But I think I'm going to qualify to talk about this. Take home. Chest pain matters. All of us will agree. Syncope matters. Most will agree. Shortness of breath matters. And palpitation matters. Ladies and gentlemen, all cardiac symptoms matter. That includes palpitation. I feel that palpitation has been somehow neglected and somewhat discriminated for a long, long time. Ask yourself, when a patient comes to you, say, doctor, you suddenly say, okay, pay attention. When a patient comes to you, doctor, off and on a palpitation. You will see the patient a bit differently. True. Let's make it trending. Palpitation matters, all cardiac symptoms matter. With that, I thank you very much for your kind attention. Together, join us at Twitter, Dr. Kaur, me and Dr. Kaur, to learn more about EP and other related topics.